In this module, we're going to cover pediatric feeding disorders. I'm going to talk about what we do in our pediatric feeding disorders program at the Scott Center for Autism Treatment. We have a feeding clinic, and in that clinic I have the pleasure of serving children in our clinical service for assessing and treating feeding disorders, and I also have the pleasure of training students how to engage in assessment and treatment of pediatric feeding disorders. And we're going to describe both what we do here at the Scott Center, but also, of course, the broader literature in the assessment and treatment of pediatric feeding disorders. For an overview of what we're going to discuss today, well, first we're going to define what a pediatric feeding disorder is in the first place. How do you know that there's a problem that needs to be solved? So we're going to very clearly articulate that using definitions that have been established both in the medical literature and also in the behavior analytic literature. We're also going to talk about the history in the literature of behavior analytic feeding assessment and intervention. We really owe a great debt of gratitude for the development and maintenance of this entire field of a behavior analytic approach to pediatric feeding disorders to Dr. Kathleen Piazza. So Dr. Piazza is known as the world's foremost expert on pediatric feeding disorders, and she developed the program at the Kennedy Krieger Institute at Johns Hopkins University years ago. She then developed the program at the Marcus Institute. It's now called the Marcus Autism Center, but the Marcus Institute at Emory University, and then established her most recent program at the Monroe Meyer Institute at the University of Nebraska Medical Center in Omaha, Nebraska. And the vast majority of what we're going to cover today is directly related to the research that Kathleen Piazza and her colleagues have done over the last 20 years, 20 plus years. And in fact, much of this presentation today is based on the training I received from Kathleen Piazza as a predoctoral intern and a postdoctoral fellow. So we owe a great debt of gratitude in the community for what Dr. Piazza has done for pediatric feeding disorders. Okay, so we're going to cover what is a pediatric feeding disorder. We're going to talk about the applied behavior analytic, or the ABA approach to assessment and intervention for feeding disorders. And so I suppose I should get this out of the way right away. We're not going to cover any other approaches. And so if you have ever worked with children with autism or other developmental disabilities, you probably have come across children who have feeding disorders, whether it's food selectivity or food refusal. And you probably have come across children who have had exposure to some sensory-based interventions or something like that. And the fact of the matter is, in behavior analysis, we're only going to use treatments that have an empirical support, right? There's got to be some sort of empirical support for the intervention for us to use it. It's in our ethical guidelines, and as scientists, that's what we do. So there are other types of feeding treatments that are used with children with autism and related disabilities, but because they lack an empirical database, we don't use them, and therefore we're not going to talk about them. What I would do is refer you to some of the literature out there that directly compares behavior analytic approaches towards pediatric feeding disorders to these other approaches. And you can see for yourself why we're fully committed to the behavior analytic approach for feeding disorders. We're going to cover some of the practical aspects of conducting an assessment and an intervention for pediatric feeding disorders as well, such as the very basics of food preparation, how to do data collection, how to actually execute the assessment and the intervention. And again, this is designed to be a standalone informational and educational opportunity, but it very well leads into a practical experience that you can get either at the Scott Center or somewhere else, so that you can learn the ins and outs of conducting assessment and intervention for pediatric feeding disorders. Finally, I have a separate bullet point for this. Doesn't really need one, but I did this for emphasis. We're going to talk about caregiver training, and the reason we're going to do that is that for a pediatric feeding disorders intervention to be effective, just like any other behavior analytic intervention, you're changing the environment, and so the environment needs to be trained up and prepared for the individual to have continued treatment success. And so we spend a lot of time training caregivers how to do the treatments that we establish, so that when the children leave our clinic and they go home, they experience the exact same treatments in the home as they do in the clinic. So next we're going to define a pediatric feeding disorder, and we're going to have a heavy focus initially on the child's behavior. So despite the caregiver's persistence at getting the child to eat foods that they wish them to eat, the child fails to eat a sufficient amount of food to either sustain body weight, to meet your nutritional needs, or to grow. So just very briefly, to sustain body weight, and we're going to get to this later, there's a particular weight that a child should be at a particular height at a particular age. And there's statistical models around that. They can tell you whether someone is at the right weight for their age and for their height. And so if you have a deviation from that, you may have a pediatric feeding disorder. We've seen children in our clinic who are underweight, who are normal weight, and who are overweight, but they are not eating a diet, all three of the groups, not eating a diet to meet their nutritional needs. So we had an example of a child in our clinic whose entire diet consisted of a giant bag of, like a family-sized bag of potato chips, bananas, and Sprite. He was normal weight, didn't look too different than anyone else you might expect his age, but obviously those foods are not meeting a person's nutritional needs, and something needed to change. And then finally, if you don't have enough food, you're not going to grow properly, and so growth can be compromised if you don't have enough of the right types of foods. So for some operationally defined symptoms of a feeding disorder, and these come from the medical literature, if a child evidences any one of these characteristics, and incidentally, many children who have a feeding disorder will be characterized by some or even all of these different characteristics, right? So your weight for your age being below the 3rd or 5th percentile. If your weight is below the 3rd or the 5th percentile, you'll typically get a diagnosis of failure to thrive, and that's indicative of the fact that your weight is so low that your body is not able to grow at the rate that it's supposed to for your age. Second, a child experiencing 3 consecutive months of weight loss. So typically children will grow at a fairly steady rate. There might be some months where there's not much weight gain, and then you'll have a jump, but you'll see a steady increase over time in weight. Children are not supposed to, generally speaking, lose weight, and so if there's 3 consecutive months of weight loss, that might be a concern. Your weight might cross more than 2 major percentiles downwards, and I'm going to show you the actual data sheet for tracking percentiles, so you'll get to see what I mean there. If weight is below 80% of the ideal weight for your height, you may have a pediatric feeding disorder, or if there's a decrease in what the expected rate of growth is for both height and for weight for your age. So these are all the things that you should look at typically with your medical doctor when determining whether there's a problem and that you might have a pediatric feeding disorder. Okay, next we're going to talk about some typical habits of children, the types of eating and drinking habits that we would expect for good nutrition, good habits, and then we're going to talk about some atypical type behaviors that are likely to occur in someone who has a pediatric feeding disorder. And we'll start with very young children. And this might seem kind of odd to state, but yes, it's typical to accept breast milk or formula. And some children actually do have a hard time with that. And it's not, sort of talked about a lot or well known, but we do see children that come into our clinic, right? A parent will say, my child was nursing and then just stopped. It just isn't taking breast milk anymore, or is now rejecting formula, and I'm having trouble getting calories into my child. Now, for most people, that sounds really counterintuitive, right? I mean, if you think about your own eating habits, if you skip breakfast and as lunchtime approaches, maybe you're in a bad mood, your stomach's grumbling, it's hard to think about other things, and it's probably hard for you to conceive rejecting food for a day or 2 or 3 days at a time. But we do see that in some of our children who come into our clinic. Typically speaking, a baby will start eating some baby food or yogurt around age 4 to 6 months, and then we'll move on to mashed, pureed, or softer foods like little pieces of pizza crust and things like that by about age 12 months. Right? So that's a normal, typical progression of feeding. Children who have a pediatric feeding disorder might reject baby foods and then have trouble transitioning to other textures. And so another common thing we see in the clinic is you might have a kid who's 2.5, 3.5 years old who's bottle dependent. right? A child who's drinking 7, 10, 12 bottles a day in order to get enough calories, because that child just never transitioned to baby food, which of course is the gateway to transitioning to pureed food and soft foods, and eventually to eating, chopped up versions of whatever your family's eating for dinner, until finally you're simply serving your child whatever it is your family's eating for dinner that night. So it is not at all uncommon for children without pediatric feeding disorders to, once in a while show some of the kind of softer symptoms of a disorder. So for example, every parent will tell you that at some point in time their child transitions from just eating whatever you serve them to maybe showing some picky type behaviors. In fact, I remember my wife and I laughing our heads off at our first child. We feed her green beans and she'd say, after eating pureed green beans, and we knew that would not last forever, and we were correct. That did not last forever, right? And once you start experiencing things that are sweeter and more tasty than something like pureed green beans. So sometimes some picky eating habits do emerge around 18 months of age. However, what's different about a child with a typical eating pattern versus a disordered atypical feeding pattern is that child will start to eat those foods again with some re-exposure to those foods. And even though you'll probably around 18 months start to see children starting to eat some foods and not eat other foods, they will definitely have a variety that is adequate to meet their nutritional needs. So a child at 18 months or 24 months who is a typical eater might not eat all vegetables, but they will eat some vegetables. Right? It's not that they will reject all vegetables. In contrast, a child who has an atypical feeding pattern might have reactions to non-preferred foods that are excessive, right? So utter refusal to even go near a certain food, throwing the food off the table, screaming, throwing tantrums, things like that. The child may have very inflexible food preferences, but then start to rotate among a very small amount of foods that are preferred. So there may be some variety, but it's going to be a very small subset of the potential realm of foods to consume, and that variety is not adequate for meeting nutritional needs. So those are all characteristics of an atypical feeding pattern that might be a feeding disorder. So for typical eaters, variety and preferences are often influenced by your peers. Right? So children are sitting with other children who are eating different types of foods, and they're interested in trying those different foods. And they might eat something because a friend eats something, or when schools have a Try It Tuesday, or something like that, where they expose children to different fruits and different vegetables. They'll do it because their friends are doing it. So there's a social influence on eating. Eating also persists in different environmental conditions. So they're likely to eat at restaurants, at home, at a friend's house, even if that food is something that is fairly unfamiliar to them. And then children who are typical eaters will actually engage with non-preferred foods when they're hungry enough, right? And that's not going to be true for children with atypical eating habits. And so children who have a feeding disorder are likely to be insensitive to what is going on around them with eating. Eating will be disrupted in different conditions. So for example, if you have a family event at a friend's house or something like that, a child with an atypical eating pattern might refuse to eat the foods because of the way they're presented or how they're presented. And then a child with a feeding disorder will, generally speaking, not eat non-preferred foods even if they've been deprived of food for a period of time. Here's an example of a height-weight chart that probably your pediatrician uses to gauge your child's height and weight. And on the left side is a typical chart here, and so there's the little white circles, which indicates someone marking off what that child's height and weight was at those different visits. And so you can chart here over the course of time what is the child's trajectory for weight versus age. And as the red arrow indicates, the growth should maintain along the appropriate curve. And so the line on which those circles fall, that's the median, right? It's the correct weight for the height over the course of that child's development. And this suggests that this child is gaining weight at an appropriate rate for the gains in height over time. On the other hand, on the right side is an example of an atypical growth chart. And as you can see here, growth is decelerating. So the child's getting taller, but the weight is going down. And so the dots are they're not accelerating, but they're decelerating. That's also indicative of atypical eating and potentially a feeding disorder. So feeding disorders can be characterized in these kind of two broad categories. The first is food selectivity. So with food selectivity, children will eat an insufficient variety of foods to meet their nutritional needs. And there's a lot of ways that this can manifest. And you see this develop, these patterns develop, especially in children with autism and related disorders. And so we'll come across children who will eat, say, just crunchy foods. It doesn't matter what it is, as long as it's crunchy, the child will eat it. Or maybe just carbs, right? So it's a very common thing in children with autism where they'll eat a diet heavy in breads and pastas, for example, or eat just chicken nuggets and fries, but they must come from a particular restaurant or something like that, right? So there's entire food groups, like fruits and vegetables would be completely excluded. And as you can imagine, that doesn't provide a sufficient variety of nutrition to keep you healthy. Second, there are children who engage in food refusal, some in complete food refusal. And these are children who don't eat a sufficient quantity of food. They literally aren't eating enough calories to meet their body's needs. And oftentimes this leads down pretty untoward path where children end up getting a surgical procedure to have a G-tube. So G-tube is when there's a hole inserted, literally right in your belly, and then there's a port and so that you can open and close, and you can stick a tube in and feed liquid nutrition so that you get enough calories to keep your body healthy. And so obviously, parents are extremely motivated to put in place some sort of treatment so that they can avoid having to have a surgical option and feeding children who engage in food refusal a liquid diet through a G-tube. There are some other symptoms of feeding disorders. I mentioned bottle dependence earlier. And again, this is when a child just never transitions off of bottles onto more sophisticated types of food ingestion or liquid ingestion. And then second, there's texture dependence. And you oftentimes will see texture dependence in children who they do develop into eating baby food and pureed foods and mashed foods, but never really develop the skills to chew. And we'll actually talk a little bit later about some of the things we've done to help kids learn how to chew so that they can properly masticate their food. So some other non-age typical symptoms. Parents might report meals that take a very, very long time and that it's chronic. I mean, every single time that they have a meal, it takes a long time and that they have to do all sorts of unusual things to make their child eat, like pay special attention and provide a lot of attention, and oftentimes there's arguments and fighting, right? And cajoling, trying to get the child to eat the food. Parents will report a failure to advance texture, right? So don't go from liquids to purees, or they don't go from purees to more solid foods. Again, having this overdependence on one source of nutrition or a very limited source of nutrition. Engaging in high levels of inappropriate behavior, which typically include saying no, pushing food away, batting at spoons if someone's trying to feed you, screaming, coughing, gagging, responses that are, generally speaking, incompatible with eating. From the parent side, so we don't want to forget about the parents either, a report of a high level of stress, not just during mealtime, but like leading up to mealtime and following mealtime. We are the Scott Center for Autism Treatment, and we do have a focus on children with autism and related disorders, and so I'm going to talk about this, these issues in that context. But of course, everything I'm saying does apply to children who have feeding problems, who don't have autism. But anyway, children with autism do present some special challenges. Their diets often consist of foods that are high in fat, lots of sodium and sugar. And so many parents talk about how their children are dependent on fast food, which is just not good for you. And candy and sugary drinks and things like that. And of course, parents are very motivated to have their children's diets shift to be more nutritional. And this is important, of course, not just for the children's current status for growth and nutrition, but for their longevity. So these poor diets are associated with risks such as diabetes, obesity, constipation, and high blood pressure, all of which are potentially bad news for having a healthy lifestyle later in life. Some people are shocked by this statistic, but it's true. It is estimated that as high as 90% of children who are diagnosed with autism show some signs of a feeding disorder. Doesn't mean that 90% of children have these extreme problems like bottle dependence or extreme problem behavior during meal times, but on one level or another, there could be some improvements in nutrition for up to 90% of children with autism. 70% of children who are described as having a feeding issue are described as being selective eaters. So 70% of the children engage in food selectivity, not food refusal. And that's a good thing, right? In the sense that these children are getting enough calories and they are eating, and many of these children are chewing. And so it's a matter of shifting either the types of foods or the quantity of certain foods to incorporate some other food, right? So maybe the kids don't eat any or enough vegetables, and the goal is to kind of shift the proportion of food away from starches and towards vegetables or something like that. So that, of course, means that the other 30% of children engage in probably more problematic level of a feeding disorder, such as food refusal. Some people have suggested, although there's no firm data on this, that the presence of feeding difficulties early in life could be an early sign of autism. And it's not that there's a causal relationship, it's that these two things tend to go hand in hand. And there's probably not just feeding problems, but a conglomerate of other deficits or kind of warning signs that can be indicative of a broader problem, such as an autism spectrum disorder. All right, so if you're anything like me, you thought to yourself, why would somebody not eat? It doesn't make sense, right? You're used to 3 meals a day, and that's probably not enough because you probably snack throughout the day, as I do, and it feels really counterintuitive, right? To say, well, how can someone just not eat? Why would someone need to be forced to eat? And even if you're giving them foods that they want and like, why would you not eat? So we'll talk a little bit about the etiology of pediatric feeding disorders. And so on one hand, there are medical issues, right? So children who, say, are nursing or breastfeeding, and then they stop, right? There's a strong possibility that that baby is experiencing reflux, right? And so most people will experience, I eat and you get pleasure. Well, these babies experience, I eat and I feel pain. And so quite naturally, they don't want to do it again, right? So if you engage in some response purposely and then you experience an aversive outcome, well, you're not likely to repeat that same sequence of behaviors that led to that outcome. There could be behavioral reasons, right? Like if a child engages in fighting or refusal behavior, somebody takes the food away. Very effective if there's a type of food that a child doesn't want to eat. And if they learn, well, if I push the food away or I throw it on the floor or scream and cry, that my parents take the food away and then you don't have to eat it, right? And so all those behaviors become a very effective means to escaping or avoiding foods that you don't want to eat. Some children have oral motor problems, and this is really interesting, that if you don't chew or learn to chew, then you don't develop the muscles that are necessary to chew even more difficult foods. And many children who don't have the chewing skill developed will actually have speech impediments because the whole musculature in the mouth is not sufficiently developed to be able to make proper sounds and to chew foods. And so a lack of practice means it's effortful to engage in eating, and so children will avoid it. And then finally, there's physiological reasons. And there's a very broad literature that shows that when you engage in really restricted eating, right, so people who restrict their calories to very low levels end up having increased tolerance for low levels of food. And so you kind of get into a cycle, right? So you don't eat, and then you feel less hungry over time. You need you need fewer calories, but then you're in a position where you need to get more calories in order to stay healthy. And so a cycle develops where you develop a physiological intolerance or tolerance actually to low levels of food, which just makes the problem worse. The best approach for assessing and intervening for pediatric feeding disorders is definitely a multidisciplinary approach. And I learned this approach directly, again, from Kathleen Piazza when I worked at the Marcus Institute back in the early to mid 2000s. And we had it was a great example of an interdisciplinary approach. And so, first you want to involve medicine. So children who go through a feeding program, if they're not already eating something, need to have what's called a swallow study. And this is just to show that a child can safely swallow liquids and not aspirate. And so if you aspirate, then there's a risk, of course, of getting liquids into the lungs, and you could develop an infection. So you want to make sure that a child's actually a safe swallower. It's also important for typically a GI doctor, so a gastrointestinal doctor, to rule out a general medical condition that could be interfering with eating, like someone experiences chronic pain in their stomach, right? And so someone in that position wouldn't want to make that worse by eating. We also bring in nutritionists, and for obvious reasons, we want to know how much of which foods should somebody eat in a given day for your age and weight and whatever your target is. So if you're a kid, say, who's 5 years old and you weigh a certain amount of pounds and the goal is in a year to get you up to a certain weight, a nutritionist can help develop an eating plan so that you can gain the weight at a very safe rate and meet your goals over the course of time. Social workers are very, very good at evaluating family stressors and helping with the family dynamics. They are great at bridging the gap between the clinical team that is serving an individual with a feeding disorder and the family who needs to learn the intervention and build in the intervention into their daily lives. Speech and occupational therapists, they're great at evaluating motor skills, oral motor skills, and safety. That's especially important if you have a child who's never chewed and hasn't developed that musculature, in the jaw, as I had mentioned earlier. And then finally, we bring in psychology to help evaluate other environmental factors that might be contributing to the pediatric feeding disorder. So here I show you a flow chart. I'm going to show you a series of flow charts on, when you have a child who comes in and has a potential pediatric feeding disorder, what do you do and how do you make decisions on how to assess and treat? And so you start with an intake, and then that typically leads to your feeding clinic, and there's a possibility of a referral, right? So you might, again, make a referral to a medical doctor for a swallow study, or perhaps the parents were concerned that the child had a feeding disorder but actually does not. And so you'd make a referral to somewhere else. And then, at least the way we do things in our clinic, you've got a choice of 3 different options. The one is what we call a day treatment program, which is the most intensive. The second is an intensive outpatient program, which is less intensive. And then the least intensive is the outpatient program. So for the day treatment program, this is typically reserved for children who have severe feeding problems. I mean, these are children who either have a G-tube and they need to learn to eat by mouth in order to decrease G-tube dependence, or this child is at serious risk of having to get a G-tube. I mean, you're trying to avoid surgery, right? And it is almost, the way you look at it is like it's an emergency. Like you maybe even you stop school for a period of time to treat this problem. Because typically the children would be in a center, all day, 5 days a week. Usually this is reserved for a child who has a history of outpatient treatment that has not been successful, right? Or for a child with emergent feeding problems. So like a child who's nursing and then stops and now isn't consuming anything. Or a child who was eating just fine and then all of a sudden isn't eating anything anymore, right? So the idea would be get the child into an intensive program and try to assess and treat the problem as assertively and as quickly as possible. Next, a child might come into the intensive outpatient program. Again, this is going to be reserved for children with severe feeding problems who have a history of other less intense outpatient options. Would also include emergent feeding problems, but then a patient who's not available for day treatment. So this might be a child who comes to a center, say, from 9 to 12 or from 1 to 4, 5 days a week if possible, but not all day. Finally, a child might be exposed to the outpatient program. Outpatient is generally speaking reserved for follow-up after day treatment or intensive outpatient. It's reserved for children who have more mild feeding problems, who have a history of outpatient treatment that has been successful, and now it's time to fade down to something less intensive, or for a patient who's not available for more intensive intervention. So I mentioned earlier that we use an applied behavior analytic approach to assessment and intervention for pediatric feeding disorders. And as you recall, I mentioned that we use that approach because it has a voluminous empirical literature that supports its efficacy. And in fact, the behavioral approach has been compared to other approaches and has been found to be, well, either superior or has been shown to work, while other approaches have been shown to not produce the same outcomes. And the basic hypothesis for feeding disorders from a behavior analytic point of view is really no different than the hypothesis that you would generate for any sort of response. And it's that there is a relationship between the response and environmental events that influence the behavior. So there are antecedent conditions that are present that produce these food refusal type behaviors, that the food refusal type behaviors produce some consequence that increases the future likelihood of those responses happening again under similar conditions. So in this case here, inappropriate mealtime behavior like the pushing away the food, the gagging, the coughing, the batting at the spoon, the screaming, the tantruming, the food selective behavior, the food refusal behavior, any other feeding issue, all those developed and maintained in part by environmental events. So ABA type interventions and assessment procedures are focused on using single case designs. We show experimental control at the level of the response class. Right? So you have one individual who's exposed to, say, a baseline and then an intervention and then back to baseline and then intervention to show precise control over the response. So we know that the intervention that we've exposed to the child is actually working. We conduct functional analyses, and again, we have Kathleen Piazza to thank for that. She published the first functional analysis of inappropriate mealtime behavior in 2003. And we've incorporated that technology into our program for sure. But you expose the individual to a functional analysis of the mealtime behavior to determine the environmental variables of which the response or the response class is a function. And in general, what we've found is that when you can determine a function, right, when the functional analysis suggests a function, 90% of the time, the responses are maintained, at least in part, by escape. Right? This is kind of neat, right? Because it's first of all intuitive. Right? It makes sense. Why are people engaging in food refusal? Well, they engage in food refusal so they don't have to eat. Right? They're attempting to escape or avoid eating either all foods or specific foods. But it's also interesting because it's fairly unusual for a specific response or a response class to be maintained by one particular variable. So this is a little bit unusual in the sense that the topography does tell you something about the probability that a response is maintained by a specific outcome, in this case here, escape. So what are children learning from the environment? Right? What they're learning is if they are presented with a specific food or a type of food or any food at all, that if they engage in those inappropriate mealtime behaviors, that they can escape or avoid eating. I mean, that's the basic relationship. They learn those responses produce a favorable outcome, which is escape or avoidance of the foods. And so a parent might remove a spoon or a fork or a cup. They might terminate the entire meal, and mealtime ends, and that could be the favorable outcome. On the other hand, they might be delivering something, right, like attention. A very effective way for a child to get a parent to pay attention to them might be to refuse to eat. Or a parent might provide toys or TV shows or any means possible to cajole the individual to engage in eating. And so when children learn these contingencies, they tend to repeat them, right? And why? Because they work. So here are some of the actions that individuals take in response to inappropriate mealtime behavior, and here's like the technical maintaining variables. So when you remove the cup or the spoon or terminate the entire meal, we would say that the response is, or the responses are maintained by negative reinforcement in the form of escape from or avoidance of eating. And if someone provides attention or provides toys, we'd say that the response is maintained by positive reinforcement in the form of access to attention or access to tangible items. So we've talked a lot about the problems that children display with feeding disorders and a little bit about the etiology, and you might be wondering, well, what the heck can you do about it? Is there a way to solve it? And so just a quick sneak peek here, and we're going to get to some of the treatments later. But yeah, there is. In fact, there are treatments that are quite effective for decreasing inappropriate mealtime behavior, which is great, but realistically, more importantly, increasing consumption of foods, right? Because that's the goal. And so there have been multiple studies, and I have a few of them cited right here, that show the power of what we call escape extinction. The power of escape extinction for decreasing inappropriate mealtime behaviors and increasing eating. It has been shown to be far and away the most effective treatment for decreasing inappropriate mealtime behaviors and increasing consumption of food. Other studies have also shown you can use differential reinforcement and non-contingent reinforcement that can really facilitate reductions in problem behavior related to meal times. But in general, if you do not include an escape extinction component, you should not expect to have great success with increasing consumption of foods. So just some practical concerns here. When you're conducting intervention for feeding disorders, typically there's separate meal blocks for solids and liquids. And the reason is that these require different skills, right? And so if someone's drinking out of a bottle, that's sucking versus eating a pureed food, which is taking a food off of a spoon, as opposed to chewing, which is masticating the food and moving it around your mouth using your tongue. And those are all completely different skills. So we typically target those in separate sessions. We usually use these meal blocks that last anywhere from 30 to 45 minutes, and then you do as many sessions as possible within those blocks. So just to give you a sense structurally of what it looks like, a day in the life of a day treatment experience. So a child might arrive at 9 o'clock, have a 30 to 45 minute meal block, have a snack, let's say around 10:15, 10:30, again another 30, 45 minute meal block, do the same at noon, say 2:15, and then again at 4 o'clock, and then go home. So 5 different meal blocks, 5 different opportunities to conduct sessions, and expose a child to assessment and intervention procedures for the pediatric feeding disorder. So here's some examples of topographies that we treat. First is packing. And incidentally, I have always just found this to be so counterintuitive. Did you ever put something in your mouth and you don't like the taste? And there's 2 things you should do about it. One is swallow it, and the other is to spit it out. And that would facilitate getting rid of the taste, right? But the last thing you will do if you don't like the taste of something is to keep it in your mouth. And so if children engage in packing, either the flavor of the food is fine, and that's not the problem, and it's the actual ingestion of the food that's the problem. But some children do this. They'll take a bite and then not swallow it, not spit it out and not swallow it. And so that response is called packing. Second is some children will expel. So they will take the bite of food or liquid into the mouth, but then spit the food out again. Some approaches that we take to solve these problems, one is food redistribution. And so if a child is packing foods, you might put the spoon in the mouth, redistribute the food into a bolus, stick it on the back of the tongue to help facilitate a swallow. We have techniques for teaching children how to chew foods. And then we also have other techniques by blending different foods to help children accept foods they wouldn't normally accept. Now, blending foods is one of my favorite techniques. I think it's really neat because it takes advantage of a very interesting behavioral principle of stimulus fading. And so there's a really neat study by Mueller et al. Published in 2003, I believe, where they show that there were some pureed foods that kids would eat readily and then a bunch of pureed foods that kids wouldn't eat at all. So this slide here shows a 90% to 10% ratio. And so let's say pears were preferred and carrots were non-preferred. And you demonstrate the kid will eat pears, pureed pears and not pureed carrots. Well, if you give the child 90% pears and 10% carrots all mixed in, and if you get the kid to accept that, well then you can probe carrots by itself. If that doesn't work, then you go to an 80-20 blend and probe it again, and then a 70-30 blend. And the whole idea is that you're slowly but surely changing the stimulus properties of the foods so that eventually the individual will accept the non-preferred food. That's been shown to be a very effective treatment that we use all the time in our clinic. Chasers are used to facilitate swallowing. So an individual who has some food in the mouth, then you just give a little bit of a drink, and that can help move the food down the throat. And then finally, a flip spoon procedure. It's a procedure that helps facilitate a swallow. So you flip the spoon over and kind of press on the tongue, and that helps produce a swallow, which increases the chances of consumption of the food instead of packing. So here's some common things you'll need in order to conduct the session. We do things high-tech, so we have laptop computers. You'll need gloves, of course, to maintain the cleanliness of the food and the materials. Feeding utensils, we use very specific utensils that are hardy. They don't break easily. Scales, we measure the weight of all the food pre and post session. I'll explain why we do that later. Usually the children are quite young and they resist quite a bit, and so we use high chairs, which makes things a lot easier to conduct the sessions. And then a timer to time your both your bite presentations and your meal blocks. And then, of course, the star of the show, the foods. So we're going to talk about the exact prompts and the exact sorts of praise and the things that a therapist says and doesn't say during a session. In general, you want to always be specific, right? So something like, come on, eat. I mean, that's not particularly specific, right? But something like holding a spoon and saying, take a bite. That's very specific. If after a child takes a bite, you say, that was awesome, right? That's nice, but it's not specific. Something like, you did a great job taking that bite and swallowing it. That's very specific. So being as specific as possible in your instructions and your praise is a good tip. You know, always being specific about what the expectations are can probably only help in your assessment and your intervention, and certainly wouldn't do any harm. Some children are what we call self-feeders, and some are what we call non-self-feeders. And so a self-feeder engages in independent eating, so they'll have a plate or a bowl and pick up a spoon or fork and have the skills to eat by him or herself. And the non-self-feeders are children who are fed by somebody else. We use the term puree texture versus table texture, and there's lots of textures in between, actually, but a puree texture is a smooth contingency, right? So you're talking about baby food, applesauce, yogurt, oatmeal, things like that. Table texture is when you have a piece of chicken or some broccoli and you cut it up into bite-sized pieces and then you eat it, right? Or a sandwich would count as table texture. Now, there's a gradient in there between puree and table texture that we very often use as we're teaching kids to increase their textures, but these are in general the two broadest textures that you'll be working with. So here we're showing you the typical progression in time for bites. And so for a non-self-feeder, you typically start with an FT 30-second schedule. All right, so FT is a fixed time schedule. So you'll start a timer when you say, take a bite, and that whole interval will last 30 seconds, and then you move on to the next bite. Of course, as you're getting more success, you might decrease that interval to, say, an FT 15-second interval, and then eventually you move towards a more naturalistic bite-to-bite interval, right? And this is how most people eat, right? You take a bite of food, you put down your fork, you chew it, you swallow it, and then you move on, right? There's not a specific amount of time that influences when you eat. You simply finish a bite, and then you move on to the next bite. For self-feeders, we usually start again with a FT 30, then move on to an FT 15-second schedule, and then on to a bite-to-bite model. And then we move on, once there's success with those models, to a portion-based meal. And then you might say, okay, the whole meal consists of one bite on a plate, and then you could fade it up to 3, 5, 10, 20, 30 bites, or whatever a typical meal would be that's appropriate for whatever the food is you're delivering and the child's age and nutritional needs. So in terms of table texture, there's a progression that we use, and the reason we do this is to keep the response effort as low as possible in order to get more success. So you can imagine, right? If you're trying to teach a child to eat, do you want to start with a giant, super chewy piece of steak that even an adult would eventually spit out? The answer, of course, is no, but you might want to start with a very small, maybe like a 1/4 inch by 1/4 inch by 1/4 inch piece of a pear, right, which is very, very soft and easy to chew. That's very easy. You get some success with the 1/4 inch by 1/4 inch by 1/4 inch, and then you can move on to a 1/4 by 1/4 by half, a 1/4 by half by half, a half by half by half, so forth and so on. For purees, we'll start with different spoon sizes. So we'll start with a baby spoon, which is a minuscule amount of food, right? Especially, say, for a toddler. And then we move on to the next size up spoons, and we ordered these specialized spoons that you can see here on the slide, a medium size and then a larger size maroon spoon. And then for drinks, same thing, right? We start with a milliliter and then move our way up. And there's a good chance that when you hear milliliter, you're saying to yourself, what is that? Because we don't use that system. But 5 milliliters is about a teaspoon. Right, so you think about when you take a bite of cereal, there's probably something like 15 milliliters of food on that spoon. So just to give you a sense of how much we're talking about here. Okay, I mentioned weighing foods earlier. This is super critical, right? So you weigh all the foods before you start the session, and then the kid eats food, right? And then you weigh whatever food's left, and that's your best case scenario, right? Is you subtract the amount of food you started with, and you subtract out the amount of food you have left, and then that's the number of grams that the child consumed. And then a nutritionist can convert grams of carrots, grams of chicken, grams of oatmeal, whatever, into calories consumed. Now, if you have a situation where a child has knocked the ball over or has expelled food, your job's a little harder, but your job's the same. So your job is to weigh your napkins, so you can take that out of the equation, wipe up all the food, place those on the scale too, so you can actually measure the food that has been expelled or rejected and thrown on the floor. The whole idea is you want to figure out food that you started with minus food that's left, and then there's going to be a number, and that's the grams consumed by the individual. So you can keep precise track of how much food is consumed. So when we talk about a bite presentation, typically speaking, this is going to be in a non-self-feeding environment where you have food on a spoon, and the bite presentation consists of the vocal instruction, take a bite while touching the spoon to a child's lips. Right? That's the definition of a bite presentation. And so the bite isn't considered presented until there's contact between the spoon and the child's lips. If you need to move the child around so they're in a good position, right? So if a child's doing this or whatever it is, you want to get in a position that is conducive to eating. And then, like any procedure that you will do in behavior analysis, whether it's in a feeding context or not, you want to avoid hesitation and make sure that you're giving, very, well-timed and very specific instructions on the interval that you're supposed to give those instructions. So in the event that you are successful in getting the food from the spoon, the bowls of food, into the mouth, your next step is to check for mouth cleans. And that usually happens at the end of the FT 30-second interval, right? So if food goes in the mouth, you say, hey, great job taking that bite. That was awesome. And then your timer starts, and then at the 30-second mark, you say, show me. And you might have to use a spoon to kind of part the child's lips. You give a prompt, hey, show me like this. And what you're looking for is food, right? And so if there's food that is greater than the size of a pea, that's generally the definition, then that will qualify as a pack. If there's food less than the size of a pea or no food at all, we call that a mouth clean, right? And if the kid didn't expel and there's no food in the mouth, well, there's only one conclusion you can draw, right? And that's the child swallowed the food. We do measure different types of acceptance. What we're really looking for, right, is what's called a 5-second acceptance, which is when a child takes a bite within 5 seconds of the prompt. So a therapist gives a prompt, says, take a bite, and then you start counting. And if the child takes the bite in the mouth in 5 seconds or less or fewer, that's a 5-second accept, right? That's a really good indication that your interventions are working, right? So you're giving the instruction, you're giving the food, and the child's taking it immediately. There's also greater than 5 seconds acceptance, and so from second 6 to, say, second 30 in that FT 30-second interval, if the child does take the bite, but after 5 seconds, this would count as a greater than 5-second acceptance. And then, of course, the mouth clean, which I defined earlier, no food greater than the size of a pea being left in the mouth. Okay, this slide here shows you some of the things you might need to do food prep. Now, you don't need all this equipment if you're in your home feeding your child. And the reason, of course, is that there's not rules around what your kitchen looks like in your house. But if you run a clinic, there are rules. Right? There's state and federal regulations. And what this slide shows you is that we're following the rules. The reason I know that is we brought in a consultant who was familiar with the rules and told us exactly what the construction we would need to do to make sure that we were compliant. And so we did a bunch of construction. And so we have these industrial size and quality sinks where we can separate out dirty dishes, clean dishes, and allergy dishes. We have a dishwasher that is, it runs hotter than yours at home. It's industrial, right? This is what they use in restaurants and hospitals. And so it has a higher level of cleaning. The food has to be in pantries that are a certain level above the ground. We show you a picture there of our scales that we use to weigh foods. There's also a picture of our cutting boards and our industrial microwave, and then our refrigerator, which has built-in temperature sensors to make sure that we're keeping kids safe who we're serving. So what are the job responsibilities of a feeding therapist who's doing assessment and intervention? Well, you'll do food prep, right? You'll cut the foods into the appropriate size. You'll puree the food if it's necessary. You'll warm foods, of course, prior to each meal block. And then you'll prep everything, right? Utensils, the session materials, foods, drinks before each meal block. So you want to make sure your kitchen has all the food you need, right? Keeping a list and doing your grocery shopping, weighing the foods pre and post session, making sure everything's clean, and then cleaning the kitchen. And again, there's rules and regulations around this, which I don't follow in my own home, right? Maybe you don't either, but it's different, right? When it comes to a professional organization, the kitchen needs to be cleaned properly every single day. So some considerations for the food. All foods have to be labeled. That includes the individual's name and then the date the foods were open. Foods that are in the refrigerator can be used for up to 48 hours. Foods in the freezer for up to 30 days unless otherwise indicated. And typically speaking, we have parents choose 16 foods during the initial admission process, and we shoot for 4 foods from each of the 4 food groups. So 4 starches, 4 proteins, 4 fruits, and 4 vegetables. What's actually kind of funny, not funny, is sometimes the parents need to change their entire family's eating habits. And they say, well, we're guilty, we don't eat enough vegetables. And I think a lot of people are in that position too. So oftentimes the family gets a little bit of a nutritional makeover when the kids go through the program. Anyway, we have a food list that we recommend, and we show it to the parents, and we ask them to pick 16 foods, 4 from each of the 4 food groups. And here's an example of the food list, right? We want to have kids pick, or have the parents pick foods that are novel for the children, but also ones that are naturalistic, right? So, if you serve these particular 16 foods on a weekly basis, well, we want to use those foods for your kids' treatment so that when they go home, they've been trained to eat those foods. The next slide here just shows you a more extensive example of our list of foods from which the parents can choose. And of course, there are times when children have nutritional needs, or there might be medical needs or religious reasons why someone might eat some foods and not eat other foods, and that's perfectly fine. You don't have to stick to this list here. This is just kind of a list of convenience to help parents kind of look at different foods and check things off. Okay, so what's the process? Well, like anything behavior analytic, it is going to be highly individualized. Will there be common features? Yeah, absolutely. You'll get an assessment, there'll be an intervention, it'll probably include escape extinction, there'll be a caregiver training component, but things can change, and we're going to take you through here what a typical feeding client will look like, including some videos. In general, though, what's the process? Well, we start with a home baseline, which I'll explain in some detail. We move on to the standard outcome baseline, or the SOBL. We move on to a preference assessment, then to our functional analysis. That leads to an appropriate baseline that we can use to establish whether our treatment is effective. We then train the parents in the clinic. We then do home visits to make sure that the treatment's working in the home or the school or wherever's important to the family. And then finally follow up to make sure that the treatment has a good level of generality. So we'll start with home baseline. Home baseline is a little bit of a misnomer in the sense that it doesn't happen in the home. We conduct this in the clinic, but it is meant to simulate the home environment. And so it's basically the first look we get at the interaction, right, between the parent and the child, and what does it look like when the kid is supposed to eat and isn't doing what the parent expects the child to do. So we try to set up the sessions to be as similar to the home environment as possible. And look, we know it's not, right? So you're in a clinic where you've never been, probably, and you're in a really sterile looking room. There's a one-way mirror, and there's people behind the mirror looking at you, and they're saying act natural. And so it's going to be weird, no doubt about that. But you do try to set up the sessions as closely as possible to how it might look in the home. So there's no therapist in the room. The parent brings utensils from the home, and they try to use the same seating arrangement as at home. And you say to the parent, okay, Do what you would do at home. And it's always caregiver fed. And we're just looking for, what does this look like in a, a naturalistic setting? Typically, we'll run 2 sessions, one of a preferred food and one of non-preferred foods. One session with preferred foods, one with non-preferred, and try to mix in 2 to 3 of each if possible. What we're trying to see is, what does it look like when the kid's eating foods the kid likes to eat, and what does the kid do when you tell the kid not to eat foods? And sometimes it can be, sort of comical, and you can get really good information. So, like, for example, you give a kid a piece of broccoli, and the kid doesn't know how to chew. But you give the kid a bag of Skittles, and miraculously, the kid can chew just fine, right? And so that gives you some good information. You have a kid who is, behaviorally resisting the broccoli, but can, eat the Skittles just fine, right? Just like the kid who's too full to take another bite of vegetables, but has plenty of room for dessert. And what that means is you get a sense of, like, well, does the kid have certain skills they only show them at certain times? Or, is this more of a medical problem than a behavioral problem? Or, how big of a problem is the behavioral problem? You can really get a sense of that from the initial home baseline. Typically we'll stop the session after 10 minutes, or if the parent says, well, I would have given up by now, I'd be done. And you stop the session then too. And so, again, the therapist is outside of the room collecting data. Here's a video of a home baseline in action. Okay, next step in the process, we move on to our standard outcome baseline, or the SOBL. So again, the SOBL is typically caregiver fed, just like the home baseline, but this is more structured now. So now we're giving the parent a little bit of training, giving the parent some instructions, and we're imposing some structure over the interaction between the parent and the child. So we train the parent to do 30-second bite intervals, rotate among the different foods, as opposed to saying, eat all this and then move on and eat all of that. There's 4 foods per session. And then we use the Scott Center utensils and the Scott Center bite sizes. But again, the therapists are still not giving too many instructions. What we're trying to get a sense of here is, if we increase the structure for the parent and for the child, does that have any impact on the child's eating or the child's behavior? Again, as I mentioned earlier, we'll conduct the solids and the liquids in separate sessions. We'll start with 12 solids per session, usually 4 pureed as a self-feeder, 4 pureed as a non-self-feeder, and then 4 table texture foods as a self-eater. And then we'll go with 6 liquids per session, 3 that are self-fed and 3 that are not. And the therapist collects data, again, from the observation room. So this is just the caregiver and the child in the session room. And here's a video showing an example of the SOBL. Next, we conduct a preference assessment. And hey, if you work with children with autism or other disabilities, or even typically developing children, you're probably familiar with preference assessments, right? You either do the Fisher et al. 1992 paired choice preference assessment, or the De Leon and Awada 1996 multiple stimulus without replacement, or one of the other variations that have come out from Hank Roan's lab or Joel Ringdahl's lab, where you use these very specific procedures that are designed to produce a hierarchy of preferred items to use in upcoming assessments. And the reason, of course, that you use preference assessments is to identify potential reinforcers in upcoming assessments. The paired choice is the assessment of choice for me. It's my preferred way to start because it gives a lot of detail about the relative preferences among all the items that you choose. And typically speaking, a paired choice preference assessment involves taking an array of items and then 2 at a time, presenting them to someone and asking them to choose one. A very interesting difference between a food-based preference assessment and, say, a leisure item-based preference assessment is that you oftentimes will get a very different selection behavior from the child, right? So if you have 2 toys and you're saying pick one, a child will often pick one and not the other and then play with it. For feeding, you'll often have a situation where you present 2 foods and the kid picks neither, right? And then per the protocol, you represent those and the kid will pick neither. So oftentimes when you do a food preference assessment, they go pretty quickly. because you get, as you would expect, for a kid who has a feeding disorder, they're not preferring anything, right? And so they're refusing to even choose a food, let alone to consume it. Next, we move on to the functional analysis, and our functional analysis procedures are specifically based off those described by Piazza et al. In 2003. And of course, the procedures in Piazza et al. From 2003 were based off of Iwata et al. In 1982 as our most instances of functional analysis. The procedures, though, in a functional analysis of inappropriate mealtime behavior are quite specialized. So you might have learned how to do a functional analysis of, say, aggression or self-injury or something like that. And if you're trained in one of those, you could probably fairly easily conduct a functional analysis with the other, right? So going from aggression to self-injury or to kicking or whatever it might be is probably an easier shift than going from those to feeding, because the procedures, while conceptually identical to the procedures in a functional analysis of those other responses, procedurally they're actually quite different. But again, conceptually it's all the same. We want to know what are the environmental events that are producing the responses and what are the environmental events that are influencing the future probability of those responses. And so the typical conditions we use in a feeding functional analysis are the exact same ones you use in any other functional analysis, right? There's an attention condition, an escape condition, and a toy play condition, typically as a minimum. We don't always use a multi-element design. We'll often use a multiple schedule, like a pairwise, so maybe escape versus a control, and then also an attention versus a control, but conceptually it's all the same as any other functional analysis. So in the functional analysis conditions, they all start the same. One bite is presented, but then what happens in each condition is different. So in the escape condition, a therapist holds the bite of food at the child's mouth, and then contingent on food refusal behavior, right, the inappropriate mealtime behavior, the therapist will remove the spoon for 30 seconds. And this is no different than any other functional analysis in which there's an aversive stimulus presented, and then contingent on problem behavior, the therapist backs off and provides a break. Of course, this is a test for maintenance by negative reinforcement. In the attention condition, again, the bite is presented, and then contingent on inappropriate mealtime behavior, the therapist provides vocal and physical attention, right? Come on, just try it. What's the big deal? Quit doing that. And again, just like any other functional analysis where you arrange for deprivation of attention, and then contingent on the problem behavior, you deliver 30 seconds of attention. And of course, this is the test for positive reinforcement in the form of access to attention. And then finally, there's a control condition. And this is just like any other functional analysis control condition, where you engage in attention and play with the individual, and that there are no programmed consequences for the inappropriate mealtime behavior, all the while the bite is presented at the lips. All right, here are videos showing you an example of an escape condition and an example of an attention condition. So once your functional analysis is complete, hopefully what you've found is that the results suggest something, right? Like that the combined inappropriate mealtime behavior is maintained by escape, or maintained by, less likely by attention, or maybe by escape and attention. And then you want to set up a baseline condition. And the baseline condition will be informed by your functional analysis and will be your point of comparison for your treatments. What the baseline does, like for any other baseline, it gives you a level of both inappropriate mealtime behavior and appropriate eating behavior, such as 5-second accepts and mouth cleans, that you can then judge the efficacy of your upcoming treatments. And so the baseline will be identical to your FA condition that is shown to influence the inappropriate mealtime behavior. If there are multiple functions identified, like escape and attention, then you might combine those two different conditions into one condition. Typically speaking, you'll have 5 bites per session with 30-second intervals between bites, and the baseline is conducted by the therapist. So you begin each trial by placing the bite of food, putting the spoon right on the lips and saying, "Take a bite." You start the 30-second interval. If the child takes the bite, you say something like, "Hey, good job taking that bite." And then you provide 30 seconds to swallow. at which point you'll check for the mouth clean, right? When you say, open up and show me, like this, and then you poke around and look for the food. If the child doesn't take the bite, then you remove the bite and present the next bite. So you take the bite off the spoon and present the next bite on the spoon. Contingent on inappropriate mealtime behavior, if it's been shown to be an escape function in the functional analysis, again, you remove the bite and provide 30 seconds of escape. If the functional analysis showed attention, then you'd keep the bite where it was first presented and provide 30 seconds of attention. So after your baseline, you will implement a treatment. So we'll talk about some treatment options next. So there are a wide variety of treatments from which you can select for sure. And it's going to be dependent on the details of your functional analysis and your baseline, and then the kind of the broader other issues, right? Like what level the kid's eating at, whether it's pure table texture, whether it's medical conditions that are relevant. And what we're going to touch on here are the treatments with the most evidence-based around them, the kind of go-to treatments that you're most likely to use in the context of treating pediatric feeding disorders. And we're going to show you 3 actual clients. Escape extinction is probably the most used intervention for pediatric feeding disorders. And it's for a very simple reason. The vast majority of feeding disorders, right, these combined inappropriate mealtime behaviors, the food refusal, they're maintained by escape, right? They're maintained by negative reinforcement. And the most direct way to treat a response maintained by negative reinforcement is by using extinction. And so escape extinction, of course, is the appropriate choice for negative reinforcement. The number one goal of the procedure, right, is keep the utensil in contact with the lip, take any opportunity that you can to deposit the bolus of food into the child's mouth, and once the food's in the mouth, to keep the food in the child's mouth, right? So you want to block any occurrences that you can of inappropriate mealtime behavior. So any head turning, hitting at your spoon, batting at the therapist's arm, whatever it might be. And what you're trying to do here, of course, is minimize the amount of time that the child's not actively engaged in escape extinction. You want to minimize any escape the child gets from the actual food going into the mouth. Like any extinction procedure, what you're attempting to do is to break the contingency between the response and the consequence. So you will continue to present that bite until either you get the bite into the child's mouth or 10 minutes, typically, and then you will stop the session and start a new session. You know, sometimes our sessions will go to 15 or 20 minutes if we think that session's not long enough, but 10 minutes is oftentimes sufficient. Again, the entire time during escape extinction, your job is to actively pursue getting the food into the child's mouth. So if the kid's moving their head, you're keeping the spoon right to the mouth, and you're trying to, jimmy in that spoon into the mouth and get that food deposited into the mouth. Here we're going to show you 2 videos. The first of a therapist representing bites that were expelled within 3 seconds of them being expelled, and then effectively ignoring, not paying any attention to any negative vocalizations or inappropriate mealtime behavior. And then we're going to show the first few sessions of escape extinction where the therapist is actively attempting to deposit the bolus of food into the client's mouth and keeping the bite touching the cheek when the child's coughing. So there's no instance of escape. Kind of next level stuff is chewing. So the overall goal of treatment of pediatric feeding disorders and the use of escape extinction is increased consumption, right? So the child's not eating food or isn't eating enough food, and the broad goal is to increase amount of food consumed. Well, for some children, the next level up is to train chewing so that a child can eat table textured foods. When you ask a parent about their goals for their child's feeding, say a child who's bottle dependent, or maybe a kid who's 6, 7 years old in first grade and goes to school with 3 or 4 containers of yogurt, parent says, I want my kid to take a sandwich to school and eat it. Or I want to be able to go to a baseball game and get a hot dog, or go to a picnic and pack a fried chicken, or whatever it is, right? Just regular old food. That's what a parent will tell you. They want their kid to fit in. And chewing can really help with that, right? If you can get kids to learn how to chew and safely chew and swallow food, that gives a big quality of life improvement for families. And so many children with feeding disorders have these delays in oral motor skills. They just don't know how to chew. And it seems like a very instinctive, easy skill, but it's really not. I mean, it's actually a fairly complicated thing to do. And so next time you have some food or piece of gum, like chew it around and see what you're doing. It's actually a really complicated thing once you pay attention to it. And so, we do chew training, and we do that, with the primary goal of equipping a child with the skills to eat table texture food, but there's other outcomes as well. So it improves the muscle strength in the jaw, it improves lateralization, which is moving food back and forth in the mouth. It teaches you to recognize when it's safe to swallow a bite, right? So you sort of instinctually do that, right? But you had to learn the proper amount to chew a bite of food before you swallow it. And so it improves mastication, which is chewing up a bite enough to swallow it. And then finally, it gets a child in a position where they have the same skills as their same-age peer, which is a great goal to include in a feeding program. So the chew procedures, like any other procedures, will vary on a case-by-case basis, but they do include some fairly typical procedures. We usually use these what we call chew tubes, and they look a lot like the tubing you'd use like for an aquarium, like for a fish tank. And the beauty of these tubes is that you can cut them out, and then you can do a couple things. You can control the amount of food you put into the mouth, but you can also prevent early swallows, right? Because the food's kind of on in the tube, and as the child's chewing, it stays on the tube, right? But what's really neat about it is because the therapist is holding the tube, you can count the chews. So as a child is chewing, you can count the number of chews that are happening, and you can actually feel whether the child's chewing hard or not. So it gives the therapist direct proprioceptive feedback that they can collect data and put that on a graph and be able to judge whether a child's actually producing good chews or chewing at all. We use three-step prompts, right? Verbal, model, and physical for getting an individual to start chewing. And then we fade out things like the bite requirement, the bite size, and then the position of the bite. And what we're trying to do is try to produce a naturalistic chewing while fading out the tube over time so that the child becomes a safe chewer and a safe swallower. So we're going to take you through an actual case. Call this child Nate. So Nate began with lots and lots and lots of practice on an empty spoon. We're really just trying to get the mechanics going. And then we fade it from doing 1 chew to 5 chews on a Cheerio. Cheerios are a great thing to start with here, and it's why babies eat them, right? Because you can practice chewing, but they also dissolve fairly easily, and if you swallow it, it's not all that dangerous. But once you chew one time independently, so we provided lots of praise and then removed the bite from his mouth, and this is taking advantage of negative reinforcement here, right? Gave him a break from the effort of eating. And then if he chewed independently, he got access to 30 seconds of an iPad, which he absolutely loved. And then if a physical prompt was needed, we gave him access to a book for 30 seconds, which he liked, but not as much as the iPad. And so this is a great example of differential reinforcement. For a chewing assessment, I'll take you through an actual client. Again, this is Nate. So we provided a rule to Nate at the beginning of each session, and it essentially described the contingencies that were in place. And so, for example, if you chew one time, then I'll take the bite out of your mouth and give you the iPad. But if I had to help you, you only get the book. And the bites that Nate took were each counted out loud by the therapist. And so once Nate met the bite requirement for multiple sessions, then we increased the requirement by 1 chew. And so we systematically did that across sessions. And then once Nate consistently met the criterion for 5 chews, then we increased the requirement to chewing and actually swallowing the bite to get access to the iPad. So the unit price, if you're familiar with the behavior analytic or behavior economic literature, we changed the unit price for getting access to the iPad. And so here in the next few slides, we're going to show you some examples of what those sessions look like. So in this first video, we will show you practice chewing on an empty spoon. In this next video, we're going to show you the contingency for 1 chew and show you how 3-step prompting works. This next video shows 1 chew. The final video shows 5 chews plus a swallow to get access to the iPad. Once the treatment has been successful for increasing eating in a bite-based session, we move on to portion-based meals, which again, it simulates a kind of more typical, family-style eating or restaurant-style eating environment. And so this is for self-feeders, so children who are feeding themselves. And you set as your typical end goal whatever would be an age-appropriate goal. So it'll change, right, as the child gets older and gets bigger and the child's nutritional and caloric needs change. So you set a goal that's appropriate for that child's current nutritional status. Essentially, bites of food are placed on the plate and the child picks up the food independently with a fork or a spoon or fingers if that's appropriate for the food. And the therapist uses a timer along with three-step guidance if it's necessary to do so. And the typical progression is 1 bite on a utensil, 1 bite off the utensil, then 3 bites, and then 5, 10, 20, and however many bites it takes to finish that age-appropriate meal. So we're going to show you an example here of a client named Hank. So Hank started as therapist fed, right? So he was a non-self-feeder. And we moved on to self-feeding sessions and then on to a more age-appropriate portion-based meal arrangement. And so what we worked on now is more on efficiency in the meal, right? And measuring bites per minute as a dependent variable. And so now that he's eating by himself, we're more focused on, well, gosh, is this happening in an efficient manner? Is the meal happening within a time frame that is reasonable for the child's age and for the family's needs? We used here prompts to kind of keep things going, right? We implemented a prompt procedure to keep the bites per minute at an adequate rate and to delay the latency between bites, right? So the delay between the finishing of 1 bite and then the initiation of the next bite. So the next video is of Hank, and he's got a 30-bite portion-based meal here, and the prompts came every 15 seconds without a bite. So if Hank went 15 seconds without taking a bite, the therapist provided the instruction, take a bite. And then if 15 seconds went after the verbal prompt without taking a bite, then the therapist moved on to a physical prompt plus a vocal response, you need to take a bite, Hank. This next video shows the implementation of escape extinction. And so with escape extinction here, the therapist uses the utensil and keeps the bite touching the cheek while the emesis is cleaned up, and then you continue with the physical prompt. So this child had some emesis, but the therapist kept the spoon at the cheek in order to continue the escape extinction procedure. And so, you really want to keep in mind, it is critical to minimize any deviation from escape extinction when you're implementing that procedure. And so even something is, as difficult to manage as emesis or other problem behaviors, you still want to, as best you can, implement the escape extinction procedure. And you can see this in how to do that in this video. Next, we're going to discuss swallow facilitation and show you an example. And so swallow facilitation is a great independent variable manipulation to use when an individual engages in packing. And as you recall, packing is defined by keeping the food in the mouth 30 seconds after the acceptance. So the bite is accepted and the individual neither spits the bite out nor swallows the bite, keeps the food in the mouth. And typically the therapist repositions the food in the mouth and then uses the utensil to facilitate a swallow response. And so in this video here, we're going to show you how the therapist executed that independent variable. Next is caregiver training. So caregiver training should be implemented after the therapist and the entire team comes up with what they think is going to be the final treatment. Right? Now, of course, the family, the caregivers have been involved the entire time in terms of selecting the treatments, and they've been getting access to some level of training. But this is like the end game, right? This is where we're saying we're going to transfer this treatment from this clinical environment with a clinical team to the people who are important in that child's lives, so the caregivers and the parents. And so once you've met all of your goals, your data indicate that you've finished your goals, you'll begin training the caregivers on the procedures. And one thing that's very important is to keep consistency across caregivers. And of course, the reason you do this is to increase the chances that you'll have success across locations, across people, and across time. You're really contributing to the generality of the treatment when you make sure everybody's on the same page about treatment implementation. And usually we just use a fading procedure in order to increase the chances that you're going to get a transfer of the treatment from the therapist to the caregivers. So here's a typical progression for caregiver training. So you might start with the caregiver observing from the observation room. So caregiver's behind the one-way mirror, so the caregiver can see and hear everything, but the child cannot see or hear the caregiver. And this is like an intense observation. The parent or caregiver watches everything, asks questions if they have any questions. Another therapist kind of walks the parent through what the procedures are to get them prepared procedurally for what they're going to do. The next is introducing the caregiver into the room, and we usually start with just kind of across the room. And so now the therapist is engaged with the client in the treatment, and mom or dad's kind of over there in the corner watching. And this is the first kind of exposure and inkling to the kid that, oh wow, this isn't just my therapist at Scott Center. Like, my life's about to change, right? Mom or dad's going to know what this treatment is, and they're going to use it. Right? So that's the kind of the layaway to describe what really is a stimulus fading procedure. Next we have the therapist kind of move closer and closer, and we systematically fade the amount of space between the caregiver and the child. Once the parent or caregiver is next to the therapist, the caregiver starts to provide praise contingent on responses that meet the definition for praise. Then the caregiver will start doing the feeding, right? And the prompting and the praising with the therapist present, and then the therapist fades out of the room, the same way the caregiver faded in, and then finally the caregiver runs the sessions independently. And the way we usually do that is the therapist goes into the room behind the one-way mirror. Both the parent and the therapist are wearing a bug-in-the-ear device so they can communicate surreptitiously, and the therapist can provide feedback, both positive and critical, of the actions that the parent's taking. And the whole point of it, is to make sure the parent feels confident, can correctly, with treatment integrity, do the treatment, and we want to demonstrate that with our data in an environment that is well controlled before we send the child and the parent kind of off into more naturalistic environments. This video shows Jake engaged in some sessions with the therapist and the parent in the room, and they're working on self-feed sessions where the bite is presented off of the utensil. The next to last step in the process are home visits. So the purpose of home visits is to arrange systematically for the transfer of the treatment from the clinical environment to the home environment. So now we're talking about generalization here, right? We want the treatment that has been shown to be effective in a clinical environment to be effective in the home, the school, the daycare, a restaurant, whatever the relevant locations are. And then, of course, to the relevant people, right? Babysitters, grandparents, whomever might be involved in the child's feeding. Typically, we would do at least 5 meal blocks conducted in the home across 5 different days, with different caregivers rotating in and out of the different sessions. And this is crucial, right, for the success of the treatment. You want as many people in as many locations over time as possible to engage with the child with the treatment, so that from the child's perspective, this is the new reality, right? These are the environmental changes that are permanent, and it doesn't matter where you go or how much time has passed, the treatment is in place. Next is follow-up. So of course, we're always interested to know if our sessions actually do have generality across time and settings and people and foods, and so we systematically test for that. So with follow-up, we're really looking at treatment maintenance, right? The extent to which a treatment still functions over the course of time, and any other challenges that the treatment might encounter between the discharge from the program and the initiation of the follow-up. And so you might have a 1 hour weekly or perhaps a 1 hour monthly session. It could be in the clinic, or it could be conducted via telemedicine in the home. Typically, we would continue those services on a weekly basis or as needed. And the whole point is make sure parents are still doing the treatments with treatment integrity and make sure the child's behavior are still consistent with the treatment goals, right? Low levels of inappropriate mealtime behavior, high levels of engagement with the food and actually consuming the food. There's a bunch of other features that are absolutely relevant for executing an assessment and treatment for pediatric feeding disorders. And in this next section, we're going to cover a lot of those. It's definitely important for you to be exposed to these in this technical type of training, but I can't emphasize enough how important it is to seek out a practical training experience so that you can actually learn how to do these things in a practical environment. And so in our system here, we use a computerized data collection system called DataPal. There's plenty of other systems out there, but I do recommend a electronic data collection system. And so it utilizes real-time data collection, and we use computers to do it. Usually there's one feeder and 1 to 2 observers collecting data during each session. We develop operational definitions of all of the child's behaviors and of the therapist's behaviors as well, so we can track treatment integrity. And so we're going to go through some of those operational definitions. So we use the letter P on the keyboard for a presentation, and that's defined for a non-self feeder as a spoon, a cup, a bolus, whatever the presented item is, physically touches the child's lips. For self feeder, it's when a utensil is placed within arm's reach of the client regardless of the vocal prompt, right? So this is when the food goes down and it's right in front of the child and it's ready to be eaten, right? That qualifies as a presentation. Next, we use the number 5 for a within 5-second acceptance. And so this is where when the client opens his or her mouth, takes the entire bolus, the entire bite, within that 5 seconds of the presentation. And of course, as it goes hand in hand with the mouth clean definition, that includes all the bolus with the exception of anything that's less than the size of a pea. We use the number 3 for greater than 5-second acceptance, and that's very similar to the 5-second acceptance definition, with the exception of more than 5 seconds elapses between the instruction to take a bite and the actual acceptance of the food into the mouth. We use D for inappropriate mealtime behavior number 1, and the list might stop there, but it could go on as well. And so we use D for every time the child touches the utensil, right? The cup, the bowl, the spoon, or the feeder's arm. And obviously when you watch it, it's the intent to disrupt, right? So you're hitting the spoon, you're pushing the bowl, otherwise engaging in some response that's disruptive to the feeding environment. Second one is for head turns, right? So every time the child moves the head more than 45 degrees away from the initial presentation of the bolus of food or drink. Also includes moving the body more than 30 degrees from the upright position in any direction. For the third here, we score only during initial presentations or during re-presentations, not typically scored during acceptances. And these are any instance of inappropriate mealtime behavior that occurs for each of the child's hands. Right? So every time an inappropriate behavior happens with one hand or the other, so if the child does something with both hands, it would count as 2 responses. So this slide here shows you an instance when there's 3 inappropriate mealtime behaviors happening essentially simultaneously, right? Child turns the head more than 45 degrees, child hits the food or the utensil, and then hits the feeder's arm from the elbow down, kind of all in one continuous movement, right? Those would count as 3 separate occurrences of an inappropriate mealtime behavior. We use the letter E for expel. And this is defined as any time food or drink larger than the size of a pea that was accepted, but is not swallowed, is then visible outside of the mouth. And what this captures is when a child is forcefully expelling, right, the food from the mouth, right, or if the food kind of passively drips out of the child's mouth and collects in their hand or on their clothing or on their bib. So expulsions covers the forceful spitting out of the food or even the kind of passive dripping of the food out of the mouth. We use S for representation, and this is every time the feeder takes food that has been expelled and places it back in the child's mouth. So if food starts to seep out of the child's mouth, the therapist would scoop it with the spoon, redeposit the food back into the mouth. We use C for cough, and a cough is when a client expels air from the lungs sharply with a noise, accompanied by the movement of the chest. Sounds silly to operationally define a cough, but we want to separate that out from other types of noises. We use G for gag, which we define as the jaw moving forward, accompanied by any of the following movements. So the tongue moving forward, the neck extending, the chest coming up and forward, the chest moving in, and shoulders moving forward. So any of those movements and that kind of a choking sound when there's food in the mouth. We use the letter V for any occurrence of emesis. And so anytime a child brings up food from the stomach and becomes visible outside of the mouth at any time during a trial. And so if the child swallows food and brings it back up, it will qualify as an occurrence of emesis. We use the number 0 for not seen. And so this is to mark a time where something happened, but the therapist isn't quite sure that they've met the operational definition for mouth clean or a PAC. So, child doesn't give enough access to the mouth to be able to see whether there's still food in the mouth, or you can't see under the tongue or anything like that. And the reason we do that is to be extremely conservative with our measures, right? We don't want to give a child credit for swallowing food if we're not, pretty sure it actually happened. So we will mark a 0 or a not sure in a case where we can't verify a mouth clean. We use 6 to measure incorrect praise, which is defined by a feeder essentially making a mistake, right? And saying, good job taking a bite, even if the child didn't take the bite within 5 seconds. And so this is a way to measure whether our feeders are providing the right sort of feedback when they're supposed to provide the feedback. 7 is defined as incorrect attention. When a feeder, say following a disruption, an expulsion, or any other inappropriate mealtime behavior, provides some sort of attention contingent on that response. So when there's an instance when a feeder is not supposed to provide a programmed consequence such as attention, but does anyway, we collect data on that because that would be a failure of treatment integrity that we would need to correct in subsequent sessions. Finally, we do use some duration keys as well. All of the other responses have been these kind of discrete behaviors that you count, and then you can divide by time to get a rate. Some responses, though, are much more amenable to duration measures, such as tantrums, crying, negative vocalizations, responses that happen over the course of time instead of in discrete units. And so we use X, but we capital X, right? So control X for timing in and timing out. And so we begin scoring when the bite or the drink comes within arm's reach of the child, and then we call it tabbing out when it leaves arm's length of the child. And the reason we do that is we want session time to include when session's functionally being run, right? So what we don't want to do is have session time running if the food's not actually within reach of the child. So if for whatever reason the food's out of reach and the actual session procedures are not in place, we want that to show up in our data stream. Finally, we use J as a duration key to represent correct implementation of a protocol. So that remains on when the feeder is implementing the protocol and the procedures correctly, and then would be turned off during the period of time if the therapist accidentally starts to engage in a different protocol or isn't engaged in the protocol as he or she should. And so, for example, if the therapist is supposed to hold the spoon up against the child's lips, but doesn't keep the food up against the child's lips, then we turn the J key off to indicate that the protocol is being implemented as it's intended to be implemented. So in summary, we've covered what is a pediatric feeding disorder. We covered some of the literature in the pediatric feeding disorders area, and we went through many of the practical aspects of assessing and treating pediatric feeding disorders. You now have much of the technical information that you would need in order to engage in assessment and intervention for pediatric feeding disorders. What I hope has become clear to you, though, is that practically speaking, implementing these procedures is a gargantuan task. It is complex, it is difficult, and it really does require training. And we hope that you can use this technical information as a foundation to getting a practical experience to put you in a good position to become someone who's skilled at assessment and treatment of pediatric feeding disorders. Thank you.